Welcome back to another edition of Sit Down with Magnolia Tribune. I'm Magnolia Tribune CEO Russ Latino. Hope you're having a great day. If you're not already following us, please give us a like and subscribe down below. Also, go to magnoliatribune.com, sign up for our daily newsletter. Over 70,000 Mississippians get newsletters 6 days a week covering news, opinion, culture, business, the things that really affect Mississippians. So we'd love to have you be a part of the family there. And on social media, you can check us out at Magnolia Tribune across all the major platforms. We're excited today about the conversation that we're going to have with Brian Blase. Brian may not be a name that you're familiar with, but he served as healthcare advisor during the Trump administration, and so comes with an awful lot of knowledge and experience in this space. Brian, welcome to Sit Down with Magnolia Tribune.
Happy to be here, Russ.
So we're going to talk today about Medicaid and Medicaid expansion. Those are big hot button issues in Mississippi right now. But before we get into that, I think the audience would just be kind of curious about what was it like being in the Trump White House? What was your experience there?
Yeah, so I was there for the first 2.5 years. So fortunately, didn't have to deal with the pandemic inside the administration. In 2017, it was really exciting. It was super pressure packed. I mean, repeal and replace and Obamacare issues were front and center. And working with Congress initially had its share of ups and downs, and ultimately more downs than ups, unfortunately. But then what I did at the National Economic Council was coordinate the healthcare policy across the executive branch. So I worked closely with the Departments of Health and Human Services, Treasury, Department of Labor, and really tried to implement the president's agenda and expand options of coverage for people, deal with existing problems with both Obamacare and other government programs. And it was a very rewarding 2.5 year experience. If you want to be in, the policy making role, and I want to change policy. I clearly want to reduce distortions with government health programs, focus on advancing freedom and limiting government. I mean, having that opportunity to serve in the White House was the privilege of a lifetime.
Yeah, certainly not a bad place to influence things if you're the president's healthcare advisor at the National Economics. So you're doing all right there in terms of influence. You're now the president of Paragon Health Institute. That's been going for a few years now, where you're advising, I would imagine, states as well as the federal government in some instances on what it looks like to implement good healthcare policy. Is that right?
Yeah, we probably spend more of our time focused on federal issues, but Paragon produced a book for states on health policy called Don't Wait for Washington, How States Can Reform Healthcare Today. And I spend a lot of my time on the issue of Medicaid. Did a recent report for the state of Florida analyzing what would be the effects if Florida expanded Medicaid. And, obviously it depends on what the political dynamics are in Washington, whether our ideas have more of a receptive audience or not. If they don't, then more of our attention focuses on working with states on implementing pro-consumer, pro-competition reforms at the state level.
So Medicaid and Medicaid expansion have been big topics in Mississippi lately. Certainly during the gubernatorial election that we just came out of, the Democratic candidate for governor pushed very hard for the idea of Medicaid expansion. And it was sort of a flashpoint in the race between the incumbent Tate Reeves, who won the race eventually, and his opponent. But even coming out of that election cycle, where arguably the side that was opposed to Medicaid expansion won, you've got this situation where there are a lot of Republicans in the legislature that are considering whether or not this could be the time to expand Medicaid. That allure of federal dollars is very, very strong in a lot of people's minds. Is there a reason in 2024 for a state to be opposed to Medicaid expansion?
There's a lot of reasons for states to be opposed to Medicaid expansion in 2024. I think probably more reasons to be opposed to Medicaid expansion in 2024 than actually in 2014, because we've learned from the experiences of states that have expanded Medicaid. I get that there's the allure of federal money, and we've seen more states over time adopt Medicaid expansion because they want to access the additional federal money and the healthcare industry within the states, both the insurance industry, where most of this money would get funneled through, as well as the hospital industry is pushing for Medicaid expansion, but it is not the conservative position to adopt Medicaid expansion. It's not conservative in thinking about how it would increase significantly federal budget deficits, but that it also takes resources away from the people that Medicaid is intended for: pregnant moms, low-income kids, people with disabilities, and uses resources that should be going to them on this able-bodied working-age adult population.
So talk a little bit about some of those reasons from a cost and enrollment standpoint. You always see these estimates that say, hey, if we expand Medicaid, the cost is going to be minimal, $100 million or whatever the number might be. And we're only going to add 200,000 people to the roll. Now, mind you, Mississippi's got 800,000 people already on Medicaid, which is close to a third of our state. It will be a third of our state with a 200,000 person bump. But what's been the experience in other states in terms of, have they hit those estimates, or are they way overrunning those estimates in terms of enrollment and cost?
Yeah, and I think that's a good question, is whether you want a third of the state enrolled in a welfare program. Like, is that how you want them to get health insurance and healthcare, is through a welfare program? So it's a good first question. What have we learned from states that have expanded Medicaid? They all made estimates of both enrollment and spending, and across the board. And this is in Paragon's most recent paper. We actually have a table that shows the projections and actual enrollment and spending. Enrollment is 50% higher than what was expected, and spending is a third higher than what is expected. And part of that is also, the incentives that come from the expansion and the incentives with insurers. Like, they're going to have an incentive to enroll as many people as possible in Medicaid, regardless of whether those individuals use any health services or not.
So I'm curious about the cause of the underestimates on enrollment in particular. I know in Louisiana, we heard a lot of conversation about what you saw was that small business employers that maybe didn't have very high-waged employees were dropping their small business insurance, going out and getting their own insurance plan, maybe on the Obamacare exchange, and then allowing their employees to get on Medicaid. Is that one of the drivers? Are there other drivers that are behind, the enrollments actually far exceeding the estimates?
That is definitely a cause. I think another cause is that states haven't done proper eligibility reviews. So the federal improper payment rate almost quadrupled with the expansion. It was about 6%, and it went to close to 25%. And most of that is that states, in part, I think they just had a flood of people applying for the program. In the initial years of the expansion, the federal government was paying 100% of the cost. So, you could think about what the incentives facing states are when the federal government's paying the entire cost. It's 90% now, and you're seeing, states just not being as careful because it's mostly not state resources.
Yeah, it's interesting you bring that up. Obviously, like the rest of the country, we had this period for 3 years because of COVID where there was no disenrollment, right? Continuous coverage was happening in Medicaid. Once someone was eligible, there weren't eligibility checks going on. Now that eligibility checks have taken place or starting to take place, we're actually hearing a lot of folks in the media right now basically say, oh, look, the Division of Medicaid is just dropping all these people off of Medicaid as if it was some arbitrary action. The reality, if I'm understanding it correctly, is that you essentially had people who weren't eligible getting put on Medicaid and then staying on Medicaid for that period. And really what we've got now is an effort to get back to eligibility.
Absolutely. I think the media coverage of what's gone on with what they're referring to as the Medicaid unwind is very misleading. So in early 2020, with congressional actions on the pandemic, they were concerned that people would lose their jobs, they'd lose health insurance. So they sent more money to states through Medicaid, and in a condition of that additional money, states couldn't remove anybody from the Medicaid program for the duration of the public health emergency. So the public health emergency lasted a long time, right? There's sort of a political decision of the Biden administration to extend the public health emergency. But that meant for over 3 years, states couldn't review eligibility and remove people who were no longer eligible for the program. And go back and think, at the beginning of the pandemic, a lot of people did lose their jobs. Their income dropped. They qualified for Medicaid. But for most people, the spell of unemployment was pretty short. Within a few months, they were back at work. Many of them are back on employer-sponsored health insurance, and they were duly covered then with both Medicaid and employer-sponsored health insurance. So taxpayers were totally getting ripped off during this period, right? Because they were paying a monthly check to health insurers to cover somebody who was already covered by an employer plan. And finally, this past spring, states could start rectifying that problem and removing people who were ineligible for the program. So the vast majority of people who are being disenrolled for Medicaid are already covered by their employer, or they're eligible for a tax credit to purchase a plan on the Obamacare exchange.
I think that's helpful context, because we keep hearing from a lot of people, oh, these are all procedural disenrollments. It's not that they're not actually eligible, but part of eligibility is proving that you are eligible, right?
That's right. And think about the incentives facing somebody who gets one of these notices and is already on health insurance, right? What would I do? I would just press delete or just throw that mail away. But what they're calling that a procedural disenrollment, and that people are getting trapped in red tape. But for the most part, and there is definitely cases where there are eligible people who don't respond and are removed from Medicaid. But the vast majority of those procedural disenrollments are people who have other coverage. And I have one other important point to make about the fear mongering on this. There is a policy requirement. It's something called Medicaid retroactive eligibility, where if you are eligible for Medicaid and you're not enrolled in the program, but say you show up at a hospital and you need healthcare services, you can enroll for Medicaid on the spot. You can enroll for Medicaid for most people 3 months retroactive and have your services covered 3 months retroactively. So you're effectively, as long as you're eligible for Medicaid, you're still covered by the program.
So that's helpful information. What about people who say, look, at some level, we don't care about the cost overruns. We don't care if half the state ends up on Medicaid. The point is better healthcare outcomes. And we think giving people Medicaid leads to better healthcare outcomes. What is the data on that from across the country? And that's a broad question, so forgive me if it's too broad. But
let me start by saying a significant portion of the people that gain Medicaid will replace private coverage with Medicaid. So in Florida, Milliman did these estimates, and they estimated if Florida expands, 65% of the people who gain Medicaid will replace a private plan with Medicaid. Private coverage is better for most people because providers are more likely to accept private coverage. So a lot of the people who enroll in Medicaid can't find a usual source of care and end up going to the emergency room. So one of the talking points of then President Obama, Speaker Pelosi, was that with Medicaid expansion, individuals would find a usual source of care and stop using the emergency room for non-emergent services. And I think we all recognize there's a problem when people go to the emergency room for non-emergent services. It's both costly, and it also takes resources away from people that actually have healthcare emergencies. That theory has been completely debunked. It turns out Medicaid expansion has led to a soaring use of the emergency room for non-emergent services. So that's one problem that comes from Medicaid expansion. The other problem, so the second problem is you are, and this is one of the main problems and points I make on Medicaid expansion, is it is the federal government discriminating against pregnant moms, kids, and the disabled in favor of the able-bodied, right? It's paying a much higher percentage for the able-bodied. States are responding to that incentive by taking resources away from the kids and the people with disabilities and spending them on the able-bodied. And Mercatus has a couple of really nice studies that demonstrate that effect. The last point here is that when you increase demand and an expansion of Medicaid increases demand, you're not doing anything on the supply side, right? There's nothing here that is increasing the number of doctors, the number of nurses, the number of people that are taking care of patients. So you're having a reallocation of healthcare services. And it's often going to be the case that this reallocation is taking resources away from people who most need the healthcare to people who don't need it as much. So we have no evidence of any population health improvements coming from Medicaid expansion. And actually, we have some evidence that Medicaid expansion has led to worse population health outcomes, in that if you look at mortality rates, the first 3 years of expansion, states that expanded had worse trends in mortality rates compared to non-expansion states.
So that's interesting, because I think one of the arguments that you hear frequently is, hey, look, if we expand Medicaid, you are increasing demand, but by increasing demand, you're going to increase the supply of medical providers, right? More people are going to want to be doctors, nurse practitioners, open clinics, because you now have more payers available. In practice, has that happened? And if it's not happening, why is it not happening?
No, I mean, and this would be one of my policy recommendations. And, I'm not familiar with where Mississippi's policy is here, but you should liberate providers to best treat patients consistent with their education, right? And unfortunately, it's a case, I know a lot of states in the South have pretty restrictive requirements on like the scope of practice that can be done with nurse practitioners, nurses, physician assistants, dental hygienists. Like, that's the best way to help lower income people, is by expanding the ability of sort of the lower cost alternatives, medical practitioners, to meet their healthcare needs.
And I guess part of that equation is the reimbursement rates for Medicaid being what they are, and the fact that there are already a lot of doctors within the existing pool that don't take Medicaid patients because of those reimbursement rates. That's one of the things that doesn't lead to what a lot of people intuitively think, hey, if we increase the amount of payers, we're going to increase the amount of providers. The reimbursement rates essentially act to negate that, right?
That's right. So Medicaid will often pays for primary care physicians probably about half of what they'd be paid by commercial payer. Medicaid pays somewhat better for hospital-based care, and hospitals have developed these pretty complicated supplemental payment and sort of these financing structures where the Medicaid program is more advantageous for them. But for your rank and file physicians, Medicaid is oftentimes, it's well below the cost of providing care, the reimbursement that doctors would get.
It's interesting, and this is anecdotal, but shortly before Thanksgiving, my wife shared with me a Facebook post from a mom's group, and it was a mom saying, hey, look, I've got a kid who's having all these physical and mental problems. We're on Medicaid. We can't get in to see somebody until the end of January. Right. And so in that, sir, and it's anecdotal, right? That may not be everybody's experience, but the thought that struck me in reading that was, now imagine there were 300,000 more people suddenly in the system trying to get the same access that this young girl needs. And it kind of gets to what you were talking about earlier. Are we taking the most vulnerable people and diluting the market for them by adding people who may not be as vulnerable to the marketplace?
Yeah, I mean, I think that's one of my main policy takeaways from Medicaid, is that the program was designed to serve sort of a very narrow group of low income, more vulnerable people. And the program has been expanded to such a large degree that it's lost that focus and then doesn't serve anybody particularly well. I'd say another thing, we looked at in Florida, like if Florida were to expand Medicaid, there'd only be 1.5 workers in the state per each Medicaid recipient. And just think about like the long-term sustainability of that program. Like we can't have so few workers to support this sort of big government program.
It's crazy that you say that because you got my wheels turning when you said that. Mississippi has about 1.2 million workers. We have 800,000 people on Medicaid today. So we're already at 1.5 workers to
Yep.
every Medicaid recipient. If you're talking about, even if the number was 200,000 and it doesn't end up being 400,000, you're talking about drawing very close to a 1-to-1 ratio of workers to recipients. And that's pretty incredible to think about if the goal ultimately is to create an environment where more people are in the workplace, more people are productive, more people are pulling from the front of the cart. That seems counterintuitive. One of the arguments that you hear a lot, and this comes a lot, I think, from the hospital industry, is look, rural hospitals in America are struggling. Medicaid expansion is the cure. Talk about some of the reasons maybe that rural hospitals are struggling and why Medicaid expansion, at least in the long term, is it or is it not the magical cure to what ails hospitals?
So we discussed this issue in the Paragon report on Florida and cite some work that's been done by the Foundation for Government Accountability because they've looked at hospital closures and rural hospital closures across expansion states and non-expansion states. And there's no difference. Like expansion is not what's going to save hospitals in rural areas. I mean, Medicaid doesn't pay high enough rates for that argument to make much sense anyway. I mean, I think there are significant challenges in rural areas. One is attracting workers to man those facilities. And I think we've got to have solutions on the healthcare workforce. Another issue is that patients bypass rural hospitals. So they're going to hospitals in more urban and suburban areas.
So one of the arguments I think people make very frequently, and you've alluded to this somewhat already, is like, look, we need to expand Medicaid for moms and kids, right? The argument point becomes sort of that emotional argument of the reason to do this is because there are children and moms that are in jeopardy. It strikes me that argument's disingenuous, but I'm curious what you think.
Yeah, I mean, the most of the expansion enrollees are childless adults and more men than women. Like the eligibility requirements for pregnant moms and kids are just more generous ex ante than this expansion population. So this expansion population is typically, a lower income, childless male who's probably, somewhere around our age.
Yeah, and you're right. In Mississippi, eligibility as a mom is up to 194% of federal poverty level. So that's a way higher threshold than Medicaid expansion, right? So more people are eligible under that threshold. The state just acted to expand postpartum care up to a year. So you have a year of coverage up to 194% of federal poverty level. And then the same is true for children. Eligibility goes all the way up to 194% and even higher for the CHIP program. And so it's always kind of struck me as a little disingenuous to say expansion is really for kids and moms when the current system is more generous than what expansion would be. You hit on something, though, around, sort of that category of people that might be eligible, men our age, people without children. One of the arguments has been, look, let's try and limit Medicaid expansion to people who are the working poor, right? That's a smaller sort of subclass of people who currently fall within that donut hole between Medicaid eligibility and then eligibility for the exchange program, the Obamacare private exchange program, which I want to talk about in a bit because those subsidies are incredibly generous as well for people who are eligible for that. What are the numbers, to the extent of people who kind of fall in that donut hole that are working poor?
So that's going to be a state-specific number. I can tell you that the state cannot expand just to 100% of the poverty line. The state, the option is to expand to 138% of the poverty line. And if the state were to expand to 138% of the poverty line, right now, the set of individuals between 100 and 138, which is probably in Mississippi, I would think a few 100,000 people in that income range that are enrolled in the exchanges with a premium tax credit that, because of recent expansions, which is a separate problem that we can't get into, but will cover basically the full cost of a premium that has very little cost sharing for the patient. So that whole set of individuals would lose eligibility for the ACA premium tax credit and move into the Medicaid program. That's one of the reasons, that's the main reason why Florida's crowd out rate is 65%. Again, the crowd out is that people who gain Medicaid are replacing private plan with a Medicaid plan.
And at this point, the federal government has not been accepting work requirement type waivers, right? At least during the Biden administration, they've been shutting down. Let's say the state wanted to look for a waiver that said, we're going to expand up to that 138%, but only working people are going to be eligible. CMS has not been approving those applications, has it?
Well, and I mean, it's actually, there's, I think, a bigger part of the story there is that CMS did approve those applications in the Trump administration, and they got shot down by the court system as being inconsistent with the Medicaid program. So I'd say if there are legislators who are advancing the idea of we'll expand Medicaid with a work requirement, that proposal should be really completely discredited. Like, there is not a feasible way right now to implement a work requirement within the Medicaid program. You would need Congress to pass legislation that the president would sign into law, which clearly this president would not do that, that would allow states to implement work requirements in their Medicaid programs.
So Kaiser's number, at least right now on the donut hole, those people are not eligible for Medicaid, also not eligible for the exchanges, is about 88,000 in Mississippi. And then they estimate that about 43% of those people are working. So that's like a 38,000 person number. What caution would you give to, expanding a welfare program for 300,000 people in order to address a 38,000 person problem? And are there other solutions that the state could look at for those working poor people who don't have access to either Medicaid or the exchange?
Yeah. So, I mean, again, I think anything the state could do to lower the cost of care, and particularly looking at, there are alternatives to sort of more expensive doctor care. Those sort of liberations are most helpful for lower income individuals. There's also a lot of alternatives to Medicaid, right? There's federally qualified health centers, there's community health clinics. Those get federal support for the state. So I think, and honestly, I think it's a better model of the structure of sort of lower income, of the public support for lower income healthcare needs than Medicaid. I mean, Medicaid expansion is running everything for the most part through health insurance companies and managed care. And I don't think we've seen a very good track record. One other really important point, Russ, that I want to hit is that this 90% match rate, it's not like locked in perpetuity that the 90% match rate will be with us for the end of time. I would bet that the 90% match rate changes, and I would suspect it changes within the next decade. It's immoral policy to have the federal government discriminate against the traditional Medicaid enrollees. It's just also horrible fiscal policy. Like, the incentives that states have to not care about the value of spending when 90% plus is reimbursed from the federal government. And I think that the number one entitlement reform priority for conservatives should be reducing this enhanced match rate so that it equals what the reimbursement rate is for the traditional state population. And I also say this was a proposal from the Obama administration when there was deficit reduction. It was sort of in vogue, in fashion back, 12, 13 years ago. They put a blended rate proposal on the table. So it's not like there hasn't been some Democrat thinking in this area too. So I would caution legislators and policymakers in Mississippi to just think that this 90% match rate is going to be here in perpetuity. And if you expand Medicaid and the 90% match rate goes away, you're going to have additional fiscal and political challenges in the state.
Brian, any last thoughts? Otherwise, I think that's a good one to close on. We've got $34 trillion now in debt. The first quarter of this fiscal year, $500 billion deficit. There is a point at which the chicken comes home to roost, even federally. But any other closing thoughts?
No, I appreciate the work you're doing, Russ. I think it's great. And I appreciate you highlighting sort of the fiscal challenges, because I think, it's one of the main things that conservatives need to do is figure out how we can reform government programs so that they are less costly. And I do appreciate you not bringing up Ole Miss beating my alma mater, Penn State, during this conversation. I was a little concerned that
you guys had a great program. You just ran into a slightly better program.
We're concerned that we don't have a great program. So and we can't ever beat the Michigans and Ohio States of the world. So it's been a frustration for at least a decade now.
Well, good luck to you next year. Hope springs fresh, right? We've got the playoff coming up next year, so hopefully we'll both in it. We'll see what happens. We've been talking with Brian Blase from Paragon Health Institute, former healthcare advisor to the Trump White House. Another great sit down today. I hope you enjoyed it. If you're not already following us, go to magnoliatribune.com. You can sign up for our newsletter there. You can like and subscribe, and you can follow us on our social media channels at magnoliatribune.com. Hope you have a great one.